last night. She's a speech language pathologist. I called her last minute. She said, of course, I'll do anything for you guys or my family. So, Madison Holbert, speech language pathologist. Maddie. I keep calling, Christy is her mother. Sorry, she looks exactly the same. Maddie Holbert, Madison.
Okay, hi everybody. Like she said, this is super last minute, so I don't have a PowerPoint, but I did want to go ahead and ask one question. Who all here who has a diagnosis or who has someone who has a family member diagnosis has participated in or had an evaluation for speech therapy? Can you raise your hands? So a lot of people. How many people knew exactly what was going on in that evaluation? There we go. Yeah, that's kind of what I thought. Speech therapy is a big overall umbrella term for a lot of things. We work on a lot of things just outside of using words or understanding words, and so it kind of gets a little confusing, especially when it comes to the evaluation process. So that's kind of what I wanted to talk about at the beginning. I'm a little nervous, so I'm sorry. If I stumble over my words, it's okay. I know how to fix that. Maybe. So what I kind of wanted to do is go into the diagnostic process first, what we would do to diagnose speech or language or swallowing or cognitive things, issues. First, what's going to happen is we need a referral from your doctor. Of course, everyone else has had an evaluation or has had speech therapy, but I just wanted to go ahead and start with this. So we need a referral from your doctor, and that piece of paper is probably like this much information. We might get a diagnosis on there, what the doctor has already given, like a medical diagnosis. We might just get like a random guess from doctors. So that's how much a speech therapist knows coming into the evaluation. We're gonna get, I know I had one recently where it was just like unspecified language disorder. Okay, I have no idea what to do with that. So what we're gonna do is we're gonna give like a battery of assessments, and those are standardized assessments. That could be whether with language, receptive, like what you hear and understand, expressive, what you say, how you say it, kind of like grammar rules, but going back all the way to birth. And then pragmatic, which is your language and how you use it. You know, how you use it to connect with people, how you use it to request certain things. There's different pragmatic functions. We'll go about that later. But outside of language, there's also articulation, your speech sounds and how you say them, the oral motor movements that it takes to make an actual sound. And then fluency, which would be more like stuttering or anything like that. And then also feeding, again with the oral motor movements of what it takes to actually chew and swallow the food. And then sensory, you know, are there any texture aversions? Are there any things like that? Those are kind of the things that we're going to look at during the evaluation. Now with language, articulation, and fluency, we're going to use a battery of standardized assessments. What that kind of means is we're going to give a test, and with these tests, it's going to feel super daunting as a parent to kind of watch your kid take this test, and it's going to feel really heartbreaking, because to me it's kind of heartbreaking to give the test. Because it goes off of developmental norms. And developmental norms, we all know, especially in this kind of environment with this population, developmental norms put pressure that create really a looming situation, because you know in your heart of hearts, like, they're not going to be able to do that. You're looking at the therapist, and that therapist is asking your kid, hey, can you, like they're showing some pictures, what is this? And you know they're not going to be able to say that. So that's really hard to sit and watch, and it's really hard to do. But with standardized assessments, most of the time what a therapist needs is, I need a kid to get a certain number in a row wrong so I can stop giving the test. Before they get a certain number wrong, I can't stop. If they get 2 wrong and then they get 1 right, I've got to start all over again and keep getting a certain number wrong. So when you see your therapist giving a test and you're like, oh my goodness, they're getting so many wrong, I don't know what to do, like I know my kid can do this or I know they can't, it might be because I'm a new face and you know, they don't know me, they don't trust me, so they're not going to show me all their skills, they're not going to show me all their tricks and secrets. But as a parent sitting and watching that and seeing like, okay, they're not doing this in front of this person, I know they can. or oh my goodness, am I such a bad parent, or because they can't do this yet. That's really heartbreaking, but that's totally normal in a situation. I know it's hard to say, but it's normal because we have to get a certain number wrong to stop. And so what we're trying to get with a standardized assessment is we're trying to get a standard score. I don't know what you guys had in school for standardized tests or anything like that, but I usually think of it like the CRCT is given in Georgia, which is just at the end of the year. You have a test and it shows your progress with what you've learned. And so with that, what we're looking for is a standard score in between 85 and 115. That would say that things are typically developing. And I say that with air quotes because that's funny. But typically developing, that would tell us that, you know, everything's right on track for what we would expect for this age group or this chronological age. Anything below that would say, hey, we need to do some extra work in these areas. And the areas that we would need extra work on just initially for an initial evaluation, the first time walking in the door, the areas that I would work on would be the things that we got wrong on the test. So, I guess, does that make sense? Does anyone have any questions about that before we move on? Okay, good. Just making sure I explained that pretty well. One thing that I do want to go ahead and say is the standardized assessments are not normed on differently abled people. For a standardized assessment to come into fruition, a whole bunch of people have to take the test, and then at different ages and different groups, and we have to see, you know, where do people stop in these certain age ranges? What should we say is like typically developing for certain age ranges? And that's all good and fine if you're going to give one of these assessments to somebody who is neurotypical or typically developing. But once you give an assessment to someone who is not neurotypical or typically developing, of course those assessments are going to look a little different, because you have people who have, especially like our kids, you have people who learn in different ways or acquire language in different ways, acquire skills in different ways, they'll have a skill here, and here, but then they'll miss halfway through, and then they'll branch up and have a skill totally out of the blue in a totally different area that they're, developmentally not supposed to, because they're not that age yet, but they're doing great things up here, but within their developmental age range, they're not meeting those criteria. So standardized assessments are a little bit tricky, but the reason why we have to give those is the all looming insurance. So I hope that kind of clears things up. At least I don't want to give the test. I don't want to see a kid get test questions wrong. I don't want to watch the face of a parent in an initial evaluation just kind of drop as we keep going on with the questions and as things get wrong. But it has to happen. And if that kind of thing hasn't been explained to you, I'm sorry. I try to explain it to all of the parents that come in my room that, the test that I've given your kids as a speech language pathologist does not determine the worth that your kid has in any way. That's not, what they can do or what they can say or what they can understand, that doesn't determine their worth. That doesn't determine how much space that they can take up in the world. So I like to go ahead and do that. So I think that's all from there. So once we finish the test, what you're going to probably get is a diagnosis, a language diagnosis. And that's a little bit different from a diagnosis of DYRK1A or DYRK1A, of course. But that diagnosis can provide general guidelines of what to expect, but that's not a hard and fast, sorry, I can't read my own handwriting. That's not a hard and fast foundation of what the ability is going to be. A doctor might say X, your kid's not going to be able to talk. Sorry, your kid's not talking yet, your kid's not going to be able to walk. But there are no crystal balls. There's no limits to what your kids can do. That's one thing that I really like to tell. And when I say my parents, I don't mean like Brian and Chrissy sitting right there. And when I say my kids, I don't have kids that are biological to me. But I mean my kids in therapy, and I mean my kids' parents in therapy. So that's something that I like to tell my parents, not them. That we should never stop pushing, that we should never stop really going in and going hard and going head fast and being, or headstrong, and being those people that just keep pushing and persevering over what's going on. Because normal is a range and not a destination. You know, there are higher skills in some areas of development. That's kind of what I was talking about with, you know, within their chronological age, what they're supposed to be doing right now, they're not meeting those things. But up here, somewhere where they're like 2 years past what they are in chronological age, they're meeting those. Higher skills in some areas of development are often seen in our kiddos. And skills may be learned in a different order, at a different pace, and some may be skipped. So on these standardized assessments with these developmental norms, I don't like to present those to families. I'm not going to talk about those today. I'm not going to say, you know what, at age 1.5, this is what they should be doing. You all kind of know what they should be doing at age 1.5. You all kind of know, I say should be in quotation marks. You all know how to use Google with that, but that creates such a big pressure on us as family members, as parents, and as clinicians, you know. That puts a big pressure on me as a clinician to say, you know what, the parent wants them to be doing this, but that's not where we are right now. How do we get to point A to point B and make some stops in between? So I don't like to say, you know, at this age your kid should be doing this. That's not what I'm going to talk about, because that's not important. What's important is what your kid is doing and what their strengths are, and how I can push those strengths to get to our highest ability of functionality. And that should be every clinician's goal, every speech therapist's goal, every OT's goal, every PT's goal. What are they doing? What are they doing well? How can I make them do it better? How can I help them do it better? Let's see, where was I? Some skills that emerge sooner may be related to strengths in other areas, and those may increase motivation. That's why I say, you know, find their strengths, because nobody's going to want to keep doing something and finding out that they're not doing it well. Nobody wants to keep taking a test and failing. Nobody wants to do that, and our kids don't want to do that. So if we find where they're doing well in and what they're doing well in and push that area, then that's going to be more motivating. That's going to create intrinsic motivation, and that really is the key, is finding a motivation, especially for a speech therapist, is finding that internal motivation to get them to want to speak to me or communicate with me in any modality, in any way that they can. So that's kind of what I try to find is, you know, where are we doing, what are we doing well? Skills that are developing later may be due to more challenging aspects of development in other areas, like kids who are late to talk due to difficulty sequencing oral motor movements. That's something that we don't really think about all the time, is language and articulation, language being the words that we have, articulation being how we say these things. Do I need to get it up closer here? Or am I loud enough? I just realized that there was a discrepancy there, sorry. Anyways, the sounds that we say with our mouth creates the words, but that doesn't, if we're not saying those out loud, that doesn't mean that we don't have them here, which is why a lot of our kiddos do so well with the talking devices, because, and I have one, I'll show it to you guys later, it's really fun. But because sequencing those movements, sequencing that motor plan and creating that motor plan in our brain to be able to say, you know what, to say the T sound, I pick my tongue up, I put it right on the ridge behind my teeth, and I go tut, tut, tut. To say that sound might be a little bit difficult for somebody. So creating motor plans to say different sounds and have those sounds create words might be difficult. So you might see someone who's a little bit later to talk. That's something that I see a lot of the time, is that it's not necessarily that they don't have the words, they don't have the motor plan. So also, before I keep going, I want to say that I've been a speech therapist for a year. Okay. Sorry. Don't want to lead you on there. But yeah, been a speech therapist for a year on one hand, and I've been a speach therapist for a year on the other. Take it as you want. Also, that could be sequencing that oral motor movement could also be related to, if a kid was early to roll over due to reflex and not wanting to be on their belly, like sequencing that motor plan. But then again, keep that with discrepancy because every kid is different, every ability is different. You're gonna see, I'm not gonna sit here and tell you, this is what speech in our kids look like because that's so widely different and there's such a small pool of kids to pick and choose from about what speech is going to look like. But other factors can facilitate or compromise rate of progress. Access to skilled intervention, general wellness, reinforcement of functional skills, sensory needs, and attention issues. Those kind of things are going to affect our progress. Those kind of things create a hierarchy of needs. Are our medical needs met? Are our attention needs met? Are we getting intervention from somebody else who is engaging and is fun and is one of our friends? Because that's a big thing with me. I want to be my kiddos' friends. I don't want to be their speech therapist. I want to be their friend. Because fostering a good relationship and fostering a happy and healthy and positive space with those kids is really integral to getting to seeing some progress. The goal is and should always be working towards their highest potential. That looks different for everybody. Making activities of daily living more achievable and less difficult, that looks different from everybody. But those things communicate. I don't want to talk about communicating our basic functions or communicating those kind of things because that looks different and that feels different for everybody. But we should find ways to decrease frustration. That's the biggest thing. I like to explain a language disorder or a language problem to the parents that walk into my room just like this. It's like if you walk into a foreign country and you don't know what they're saying and you just need to tell somebody that you need to use the bathroom. That's all you got to do. And you don't know how to do that. It's so frustrating trying to figure out gestures to say, hey, I gotta go potty or whatever. That's so frustrating. So imagining kind of being locked in and not being able to talk to somebody who you understand everything that they're saying, but trying to get those words out is very difficult. So that's a speech therapist's job, or as it should be, is finding ways to decrease frustration, finding ways to increase positive reinforcement with discussing, with communicating. You're not going to talk to somebody who makes you angry. If you're angry at somebody, you're just going to walk away. So fostering a positive relationship and finding ways to decrease their frustration is a big thing, and that's something that even parents can do too. So one big thing that I think is finding a therapist that your child is comfortable with. If your child is not comfortable with that therapist, if your child is not happy to see that therapist, most of the time, fire them. I want to be fired if I'm with a kid who doesn't like me because I'm not their person. I'm not the person for them. And that goes more beyond my ego, and what I want for the kid is to be comfortable in that situation and be comfortable with somebody and find a friend and somebody that they want to talk to. So if you're seeing that your kid with their speech therapist or with any therapist, a lot of the eye contact has to do with the autism diagnosis, and I will go ahead and say I am not a therapist who makes a goal saying they will have joint attention this percentage of time, or they will create eye contact with me this percentage of time. Eye contact in communication with me for the little ones is kind of a moot point. Of course, when you get older, you want someone to look at you in the eyes and talk to you because that's more functional. But just for me, for somebody to talk to me, I don't have to have them look at me. For it to be intentional, I don't have to have them looking at me. But when it comes to looking at my mouth for motor plans, usually what I do is, and this first I have to have a really good relationship with the kid, a good baseline, because you don't start out that way. You have to build a good rapport. You have to build a good friendship. So after I have a really good friendship with the kid, after they trust me, I'm gonna have them, cue them to say, hey, let's practice, look at me, or hey, let's do this, look at me, so that I can practice the motor movements. But also there has to be that either intrinsic or extrinsic, I think that's the word, motivation to want to say something. And that's our job as therapists, as siblings, as parents, as grandparents, as caregivers, to find what makes them tick, to find what makes our kids and our friends and our family members super motivated to where they want to initiate and talk. And that's going to be, with some people, that's going to be really easy. A lot of our kiddos here have very specific interests. So that's going to be very easy for our kiddos. But for other kids, I have a hard time finding, what makes you happy? What makes you have fun? And so that's kind of the first step, is finding that, creating a good fostering relationship, and then finding what makes them happy and how I can facilitate that and how I can turn that around into, you'll talk to me, or you'll not even talk, you'll interact with me in any way. You'll look at me, you'll touch me, you'll point me, you'll point to me, you'll point to something in the room, because there are different, and now I'm going to get into that, functions of language, pragmatics. There are different functions of language. There are different ways we use language. We can request things. We can terminate an activity or say to stop. That's a different one. We can greet people or create a farewell. What's another one? I forgot. We can label things. And a lot of therapists want their kids to communicate by any way for a different number of functional purposes. So definitely get your kid in speech therapy. It's fun. Any other questions? I know you had one.
I just wondered if you're, I don't know if you're going to answer this. Since a lot of our kids have this motor planning difficulties, sometimes they're diagnosed with apraxia. Is there any exercise or suggestions you have that we can do to get these muscles working better?
Yeah, and there is, and I'm not trained in this yet, but there's a lot of people who are trained in this. The Beckman-Ohm Oral Motor Protocol. I'll spell it for you. Beckman space Ohm, O-M, Oral Motor Protocol. There are people who are trained in that, but also you can look up tips and tricks, and I can, I'll give you my email later, and I can email you about that too, if you want. Yeah.
Our son is 25. He has not had speech therapy in a long time.
Yeah.
Is it too late? I mean, he still, can't pronounce certain words and letters, combinations. Is it too late?
The question here was, her son is 25, is it too late? It's never too late. It's going to be a little bit harder. That's why early intervention is really important, but it's never too late. It all depends on, can you find someone, because now it is a little bit harder. Trauma is going to need to work a little bit harder with that. So it's finding someone who can create that motivation for him. That's going to be, I think, the hardest part, but it's not too late.
Where do you start? You start with your neurologist or
your PCP.
internist?
Most of the time, I would say start with your PCP. They should know somebody good in your area. If not, be that parent. Take on that responsibility. Look up people. If they don't work, fire them. Yeah.
I just wanted to add on to what you just mentioned about the Beckman protocol. We did that with my son, his feeding therapist, who was a speech language pathologist, and I believe it made a massive difference in his ability to chew, his ability to swallow things,
Yeah.
and his ability to speak.
Yeah. It is specifically for chewing and swallowing first and foremost, but something that is really interesting, and that's why speech therapists target feeding, and we'll go about that too. I think I heard a question about that the last time, about feeding and swallowing and different diets, but those are all the same muscles, and so exercising all of those muscles in any way, shape, or form, and that's, sorry, 1 second, and I'll get to this one. That will create strength and improve their range of motion, and what's the other word I'm looking for? I've lost it. Anyways.
I feel like really, really helps.
It does. That's something that I believe strongly in, and you know, it might be. Once again, I've only been working here for a year, so don't take everything I say as hard and fast. But
The feeding and the chewing progresses speech.
It-
We figured out the more he can talk, the more he can chew, the better he can chew, and use his tongue. And
Same
better he
muscles.
talks when he's slow.
yeah, same muscles.
I agree.
Okay.
When was Beckman Home introduced?
Gosh, I'll have to look that up.
Okay, I
Yeah.
can Google that.
Okay, I'm
Just
sorry.
Because I've never heard of it, and Catherine had reflux, every reason why a speech pathologist would have done that with her.
Yeah.
And it never happened.
Well, reflux is more of a GI issue. A speech therapist can't really manage that. I have a lot of kiddos with reflux, and it's one of the big annoyances of my life, specifically because I hate throw up. And I deal with that a lot. It's really bad. I bring like 3 changes of clothes to work every day. Yeah, it's bad. But that's where was I going with that? Lost my train of thought. Anyways, with feeding and swallowing, I heard a question about that the last go around. So I heard it specifically relating to diet, and I would also like to bring into the point of view of you're in a foreign language, because or foreign country, not language. A lot of our kiddos have a hard time expressing, you know, pain or uncomfortability or anything like that. And to be able to express that, like, hey, this food is causing my stomach to hurt. Or, hey, and of course there are a lot of GI issues that come along with this diagnosis, just natural to how it is. But a lot of kiddos are going to have a reduced diet or might be diagnosed with ARFID, which is avoidant restrictive food intake disorder, because, and that's closely related to autism. I'm not going to sit here and pretend that I'm an autism specialist or an ARFID specialist. I did do a paper on feeding and autism and that how those two things mesh, but that's my only claim to fame about this one. And you know, that was based on and my own. But and a lot of people participated in it. I wanted to go ahead and say thank you. You guys helped me get my degree. Anyways, a lot of people have a hard time expressing, you know, this makes my stomach hurt, or this is really hard for me to chew up, so they're just gonna avoid it at all costs. Or maybe there's different textures or temperatures. There's a lot of things that go into feeding. What I typically see is a lot of kiddos with texture or sensory issues or GI issues also have accompanying oral motor delays in terms of feeding and swallowing. So, any questions about that?
I know that the Simon Simplex, I think, was talking about this, and they didn't know they tracked, like,
Yeah.
the data. So as raise your hand if your kid has chewing or swallowing difficulties in this room. I think that.
Yeah, that's a lot. And another thing that I want to go ahead and say is, while I do have a brother with DYRK1A, I also have a client with DYRK1A outside of the unofficial client of my brother, who I also treat him as my speech therapist client. But that's not real. At home. It's all at home. He hates me for it. It's fine. I have another client. I'm not allowed to say her name, but I did talk to her mother, and she said that I could speak about it here. She lives in our hometown. She is 12 years old. She was diagnosed with DYRK1A December 17th, and this does tie into the feeding and swallowing, or December of 2017. She also has microcephaly, seizure disorder, ADHD, and ASD. Another syndrome that she was diagnosed with is alpha thalassemia myodysplasia, which has to do with her thyroid and her blood stuff. There you go. With her, right now, she's not working on feeding and swallowing. She was discharged from that about 3 years ago. And because her treating therapist at the time said that it was functional, but not beautiful. So her feeding and swallowing looks horrendous from the outside. You know, it looks like she's gonna choke on something, but she's not choking. She's eating. She's a little on the skinnier side, as you can imagine, but she's a decent weight, and she's maintaining her weight. So she was discharged from feeding and therapy. Again, she does have those oral motor discrepancies that we see with a lot of our kiddos, along with just like the motor planning kind of issues. And right now, what we're really hitting hard with that is her articulation. She has a lot of articulation problems, the creation of the speech sounds. She leaves out a lot of her sounds of her words, which makes her really highly unintelligible. She also uses a lot of sign to communicate, and she communicates mainly in 1 to 2 word phrases. However, she can do more. Her receptive language, what she hears and understands, her standardized score going back to that range of 85 to 115. The reason I brought that up is to kind of go ahead and share her scores with you. Her receptive language is 112. She's understanding everything you say. So one big thing that I like to say about all of my kiddos is don't assume competence. Don't assume what they can and can't understand. Talk to them like they're regular people. It's going to help with their expressive language. With her expressive language, or what she's saying and how she's saying it, her standardized score without being pushed was a 67. That's severe expressive language disorder. I just asked her the question and let her answer how she did. I did not cue her. I did not push her. I did not tell her, come on, I know you can do more. Because I tell her that a lot. And I always tell her, you can't fool me. You can't trick me. I know that you can say more. Because she can and she does. She just doesn't want to all the time, which is totally fine. Not everybody wants to talk all the time. But I don't want her to take the path of least resistance just because she can. Because if anybody in this room could have taken the path of least resistance, they would. But, we all have to overcome things. We all have to do things. And that's not different for our kids because they're people too. And they're people just like us. So I don't let her take the path of least resistance. I don't let her take it easy. I might be mean to her, not really. But mean to her in the way that I am to my brother because I know he can do more. So having said that, her 67 expressive language, when I pushed her, and this was like 3 months ago, so we're still under this current testing. When I pushed her, she got a 72. That doesn't look like much, but that kind of takes it down from a severe to a moderate to severe, kind of in my book, or expressive language delay. So that brings things up a lot. And if I keep pushing her like that, over time, that's just going to be the norm of what she does, is that 72. And then once we hit that 72 as a norm and I keep pushing her, she's going to go more. Because she's 12, she's not done. Jack's 21, he's not done. Just because we age out of pediatric stuff, I have learned more than I did when I was 18. Jack has learned more than he has when he was 18. My friend here, who we don't know her name, has learned more than she did when she was 10. So there's not a. My mom said last night something about finality, and there is a big feeling of finality when they turn to be adults, but there is not a final destination. That's going to always be different. Changes are always happening, and if you make a decision about what kind of modality your kid works best with. Do they use sign language better? Do they use a tablet better? Do they talk? Does that come more naturally to them? If you make a decision and change your mind, or you can always change your mind, you can always make another decision. There's no need to commit to one kind of cup for your kid, one kind of shoe, one kind of school, one kind of communication modality. Needs change over time, and preferences change over time. And life circumstances change over time. Just everything changes. Did you have a question?
Disagree.
Okay, sorry. All right, that's it. That's all I got. Anybody got questions? Oh, yeah.
I got a question that just fired me.
Fire.
Our publicly funded system, if I just fire you, I may be waiting 6 to 18 money to the next therapist? So is no therapy, is style therapy better than no therapy, or?
That depends. Is how bad is this therapy? Is your therapist willing to change and adapt? Because I want the parents that I deal with to be that parent. Push me, make me learn things the way that your kid is learning, the way that I push your kid to learn. You know, as a therapist, our job is ever changing. I mean, this genetic diagnosis wasn't even around 10 years ago. Beckman-Ohm is a newer thing. iPads or tablets for talkers are newer. So there's always things that are ever changing and your therapist should be. So always try to push your therapist and say, you know what, this is what we need. Be that parent. And if it's not working, I hate to say, but maybe the wait list is what we need to do. But always try to push first. Anyone else?
I was gonna say, I think about my time, especially if you're commuting to get your kid and spending overall 2 hours with being in the car and waiting in their office. If I could be home and playing games with him for 2 hours, that's gonna make a big difference. If you find a talented therapist, then great.
Yeah.
Some therapists, yeah, you can.
Yeah, as a therapist, we have to take classes every year. We have to keep going and it's not like you just get your degree and you're done learning. We have to take continuing education. So I would think and I would hope that whatever therapist you're dealing with that needs to adjust and grow a little bit, they should be willing to do that, especially because the rarity of who they're dealing with. Yeah.
Some, I don't know about all states, but colleges have, where we're at, have a speech and language clinic.
Mm-hmm.
So like they offer free speech and clinic, and it's clinicians working with the child. And you can go like twice a week, but you can do that in addition if you want. And it was just phenomenal to see how much the clinician grew and how much my son grew just from having that little bit of extra time.
Yeah.
So that's something that people can maybe look to see if there's a speech and language clinic.
So local colleges who have a speech and language department often offer, you know, treatment that is free or at little to minimal cost. Just give you some people. Yeah.
How do you feel about the communication devices? Because at first I was not a big supporter of it because I was afraid that it would take away from her using her words. But then I come to find out this past year, my daughter's teacher actually told me, hey, you know, when they do speech, she uses the device and she does really well. And I didn't think she would do really well with it.
Yeah.
So what are your thoughts on that? Do you recommend us to go that route, or what do you think?
I'm a big fan, but I am a big fan for a certain reason. There are no prerequisite criteria to getting a device. Some people will tell you that there will. There's really not. You know, the only prerequisite that I look for in terms of getting a device for yourself is, will our insurance cover it? Because I don't want someone paying $60,000 out of pocket for one of these. Sometimes they're that much. Sometimes they're not. But I don't want anyone paying out of pocket for a device. So will your insurance cover it? And if not, you know, where can we get the price? Or can we get one from somewhere else? And then also, you know, what kind should we get? Because are we going to break it? Those are the only things that I think about. But in terms of language devices, sorry, I'll get to you and then you're fine. You don't need to answer the question. Sorry, that's my dad. Anyways, I do like these. I work with a company, Toby Dynavox, to get devices. I tried to get somebody out here, a representative out here. They kind of drug their shoes a little bit. But I have a device and I can show it to you guys. Getting one is a little bit different from state to state. A lot of times we'll find that our kids are using them in the school system and we'll have really no idea. That's my biggest pet peeve as a speech therapist. So always ask about that kind of stuff, especially in IEP meetings, because that will kind of fly under the radar sometimes. Just depending on, you know, where you are and how busy. Because school speech therapy, I'm going to go off on a little bit of a tangent. School speech therapy, while it is wonderful and it does great things, it's also a lot of times can be individual, but a lot of times it's a group-based therapy. I work in a private clinic setting with peds, and so I am a big fan of private clinics, but schools are doing great things too. But also it's really hard for the school's therapists to reach out to all of the parents of the kids that they see, because they're seeing like 6 to 8 at a time. And
Does using that detract from the child wanting to talk? How do you
That was my question.
No.
together in a
A big thing for the kids that I see that I give these devices to. The thing with my therapy is this is my personal iPad. This is what I've been using with a couple of my kiddos. If you want to come by and see it, you can steal it from me. I don't care, just give it back. And you can take it to your kid, I don't care, just give it back in one piece. So this is what I use with my kids. It's out on the table for every kid regardless of if I think they need it or not. It's out on the table, it has guided access, they can't get to any games. It's always out. A lot of times I find that I try to get a kid to imitate me or say a word, or I try to model a word, and they're not gonna say it because I don't wanna repeat after you, I understand. If I can find whatever word I'm using on here, let's say toys and games. Let's say, oh come on.
Bubbles.
Did you hear that one?
Bubbles.
Bubbles, it was down here. If a kid finds that and they press it, I find that a lot of my kiddos repeat after this because there's no expectation on it. It's kind of like eating sprinkles versus eating chicken in my mind. Or eating broccoli, much rather. Nobody's gonna eat broccoli, there's an expectation there, I have to. But, sprinkles and whipped cream are great. There's not an expectation there, I don't have to. If I repeat after this, there's not an expectation there, I don't have to, it's if I want to. A lot of times, my kiddos run away from expectations, and that's just fine, because I do too. Go ahead.
So in our area, just north of here, rapid prompting method is becoming more popular. Do you have experience with that?
Graphic prompting?
Rapid
Prompting. Oh, with the letter board and the...
And the touching. So they'll say a word, and then there's like a sequence of where you touch on the mouth.
I don't have personal experience in that. I don't have personal desire to have experience in that. I find that I use more of a play-based approach with anything, just because it's a lot more fun for me and for them. So I haven't had a lot of experience in that, no, but if that works for your kid, because every kid is different, everything's gonna work. I am not the end-all be-all. Every speech therapist is not the end-all be-all, fire them. If it's not...
We haven't used it,
Yeah.
because I don't think you would appreciate someone with an autism diagnosis touching on his face.
Yeah, I find that if I need to go straight, I will.
Go ahead, maybe 2 more questions.
We
used that and it was really effective.
Yeah, we do that with Emily, but we do it with Candy. So like suckers.
There you go.
So it's kind of like a positive reinforcement.
Yeah.
So I think we have time for 2 more. Emily and I think Brandon has a
What's
question.
it called?
No.
Rapid prompting method?
Or prompts.
Prompt.
PrompTs. You can search that.
Yeah. But that was just me. I find that for the kids that I deal with, that's just not gonna fly. I cannot touch their mouth unless there's food going in it. So with the candy, that sounds like a great idea to like kind of shift that, but for my kiddos, no.
That's not really a question, but we did stay away from the communication device for a long time because of that. I didn't want him to depend on that device and not try to vocalize things. We did finally get one, and I will say I'm a slacker at home, but he does use it at school. And since he's had it, he has become more vocal. We still don't have any words. If you're friends with me on Facebook, a little while ago, I said he's going to say a word before the summer's over. He is starting babbling, and if you say something, he wants to say it with you, not perfectly or anything like that. But so I actually think that this communication device is helping bring his voice out. So if you have an information about it, I say go for it.
How old is your child?
He's 8.
One thing about communication devices is I like to think of it as another tool in their toolbox. For me, I have verbal language, I have body language, I have sign language if I want to, just because I've taken those classes. But I have those tools in my toolbox. I can use one of these if I want to. I have all of these modes of communication that are just at my fingertips. So providing something else that can possibly decrease frustration in the interim of getting vocal or becoming more vocal, you know, it's just a positive. If it doesn't work for your kid, then it doesn't work and don't use it. But if it does, then use it.
They're saying that just using the device, like you said, brings down their frustration, there's like brings down expectation, and then they have easier time speaking because they know they can be heard.
Yeah.
And then they can take their time to speak.
Yeah. I'm gonna screen share this on the talk.
Oh, okay.